Right. Can everyone see the screen, the slides I'm sharing?
No, you can't see it, Sagarika.
So you have to share the whole screen, Sagarika, not just one, then it will come.
Now?
No? Oh, yes.
Yes, it's slowly loading.
Yep.
Yes,
Yeah.
thank you.
Perfect. Right. So I want this session to be very interactive, which is why I want to request everyone to either scan this QR code or go to slido.com and just enter that number, and it'll direct you to the link of my presentation. So it's going to be a lot of question and answers, discussions throughout the presentation. So I'm going to give you a few minutes to do that. Let me know if anyone has difficulties with it.
Sagarika, are you able
Could you go to the
go to the
slide?
next slide?
Yeah, sorry.
Can you see it?
So it's stuck on slide
It's
number
still-
1. I can still scan the QR code.
It's just on
let
the
me put
side. It's not the main. Yeah.
No. Okay.
There we go.
There we go. That's moved now. Oh, have you stopped sharing?
Yeah, just give me a
Okay.
second. I think it's wrong, so I'm gonna start. Is this good?
Yes.
Share it as a slide. Make it slide. Yeah, good. Well,
Perfect. Think it should be better now.
Yeah, we can see the QR code really clearly now. Thank you.
do you want us to scan that and then?
Yes, please. I would like everyone to answer questions, give their input throughout the presentation.
That's good.
A few minutes and I'll start.
Yeah. Sagrika, can you tell them about your experience as a clinical fellow?
Right, yeah. While everyone's doing this, my name is Sagarika Pandey, like Natasha introduced. I am from Nepal. I moved to the UK last year in December 2023, and I've been working in East Kent hospitals at William Harvey Hospital for a year and a half now. I started as a foundation year 1 doctor, and I had my rotations in acute medicine, general surgery, and a health an EdgeCoop, so that's geriatric medicine. So that gave me a very good exposure to different kinds of patients. And currently I'm working as a simulation fellow. So simulation is something that's not very heard of in Nepal. And when I saw this job advert, I wanted to learn about what simulation is. And I recognized it as a very useful tool, especially for new doctors who are scared to approach patients, or if there is a new skill you've learned and you don't want to directly practice on patients. Simulation gives you that safe environment that you can practice on simulated patients or mannequins, and it does really help with bridging that gap between your clinical knowledge and hands-on approach. So that is my job. I am teaching full-time. I teach medical students. I teach foundation doctors. We have simulation courses for all resident doctors and consultants, all doctors in training, and some for a multidisciplinary team. So, so far I've had a very interesting approach to medical education. If everyone's finished joining Slido, I can continue on.
What does Slido do, Sagarika?
So it is, like I said, because when you are in a large group, it's very difficult for everyone to answer questions or start discussing. So this gives me an opportunity for giving everyone an equal playing field to give their answers, not get very bored just listening to my voice, and everyone has something to do. So it's going to be a little fun twist to our presentation today. And I recommend it to anyone who's doing presentations in the future. Just see if you're enjoying it, because I did when I first used Slido. So it can be another interesting tool for everyone to use in the future.
So, as a simulation fellow, when you do, let's say, what is the main problem when you do assessment for resident doctors and so on? Although they have a knowledge, what do you think the main important weaknesses they have? As a
I wouldn't say a weakness, but I've noticed that, for example, I have close to 2 years of experience working in Nepal, and I was working in emergency and intensive care unit. So I had very good exposure to patients, and I was very confident. But when I went to the NHS, I remember even looking up the prescription dosage for paracetamol, because that's how scared I was in a new environment. So the whole goal of today's presentation is to give everyone a simple tool to help you focus on assessing your patient. And this is something we teach everyone who comes through our door in simulation. Very, very simple, but a key thing on how you can examine your patients and manage them. Okay,
Thank you,
so as a doctor, or even nurses, when you are asked to see an unwell patient, which is generally most of the patients in the hospital setting, you need to do a quick assessment and need to come up with differentials for your patients. And sometimes if you don't have a structure, you get a little lost about what's important, what's not important. So, and also if a patient's really unwell, your own fear factor steps in sometimes. You're very overwhelmed. So this A2E approach of managing patients is a structure you can follow step by step. And I promise you, you won't miss a single thing about the patient, and you'll have all the clues in managing your patient correctly, right? So the first thing we're going to discuss today is how to recognize a deteriorating patient, followed by the A2E assessment, and how you can use it for managing your patients. I'm going to touch up a little bit about Martha's Rule, which is something very up and coming in the NHS. And honestly, I'm very pro for this going worldwide. And in the end, I'm going to talk a little bit about reflective practice. Right, so your first task, everyone please, whatever signs you can see that can help you identify an unwell patient. So if you just send your answers in. Very nice, new scores. Vital signs. GCS of the patient. Mm-hmm. Perfusion capillary. Does anyone have anything different they're thinking about? Yeah. This is all very interesting. So this is just proof that everyone knows what I'm talking about. And, you know, so what I do when I see a new patient is I just stand at the end of the bed and I look at the patient. And just looking at someone gives you a lot of insight into how they're feeling, okay? So first thing, something's not right. If your patient tells you they're not feeling okay, if the patient says, oh, I'm fine, but the family member says, no, this is not what they're generally like, or if you just look at them and you feel like, you know, they're not okay, then listen to intuition, because this intuition is what you have developed through years of medical school and practice. So that is the first sign to say that someone is not in the right state of health, okay? And our body is very good in the sense that your body is able to maintain homeostasis. It helps you cope with any illnesses. So you know, there are a lot of compensatory mechanisms in the body, which is why you see subtle signs before you see a patient who's really, really unwell. So like everyone mentioned in those answers, things such as increasing work of breathing, increasing respiratory rate, a new confusion, if they're altered, if their mental status altered, or if you just look at them and they look pale, they look jaundiced, or they have very low urine output, tachycardic. So these, even before you touch a patient, these few things can help you identify that someone is not very well, okay? So in emergencies, like I said, if someone is unwell and all your clinical knowledge just goes out the window when you see someone and you're confused on where to start and what do you do first. So just following this clear approach of A, B, C, D, E helps you assess a patient. Right, so we're doing a quiz now. What does A to E stand for?
Sagarika, what do you do when you go to A to B and you go to C, and whatever intervention you have done is not helping the patient?
I'll come to that in a little bit if that's okay, Mr. Sharkey.
That's fine. That's fine. Uh, isn't it as a resident doctor, whether you are the foundation year one doctor who is starting soon, and resident doctor coming from Nepal, whenever you are asked to see unwell patient, you'll have a lot of anxiety.
Sorry, you have?
You have a lot of anxiety any unwell patient you have been asked to see first in your lifetime? How do you
Sorry, I
prepare-
didn't get you.
So if you are asked to see unwell patient in the ward,
Yeah.
then you as a new resident doctor coming from Nepal or
Mhm.
coming from any other countries, or you as a new foundation year doctor, how do you prepare
Mhm.
yourself? Because you become so anxious. How do you prepare yourself in that scenario?
Honestly, this is the key to that anxiousness, having that structure and practicing it so that it comes just second nature to you. That is the best thing you can do as a new person in the NHS. Right, so 96% are correct. Your A stands for airway, B stands for breathing, C is your circulation, disability, and exposure. So we're going to go step by step on how to assess each of them and what things you can do to manage your patient if there's a problem in any one of these. Okay? So another question. You must complete the entire A2 assessment before starting any intervention. True or false? Sorry, I'm just waiting for everyone to finish. Okay. Right. So 85% of you are right. You actually do not need to wait for your assessment to be over before you start interventions. So the whole concept of A2E is you focus on the things that kill you first. Okay, so if someone's not breathing, they're more likely to die sooner, or they're already dead and you need CPR. Or if they have airway problems, it's going to affect everything else in your body. So your A, B, C, D, E is structured in such a way that you treat the things that are likely to kill you first. Okay, so you start with your airway. If there is a problem in your airway, then you manage it. If not, you can move on to your breathing and so forth. If you've reached, if your patient has airway intact, they're breathing fine, their saturations are normal, but then you reach C and you find that their blood pressure is low and they're tachycardic, then you can give fluids immediately, take bloods, and then you can move on to your D, check everything in your D, and then go on to E, right? So the whole thing with your A, B, C, D, E is do your assessment, whatever you find, treat it, and then move on. And once you've finished your entire assessment, you reassess, right? Something very important in this is your question, Mr. Shrestha. Is when there's a change in a patient. For example, you're assessing a patient who's well and good, they're breathing, they're talking to you, and then you've reached disability, for example, and you suddenly notice that they've fallen unconscious. Then you do not continue your assessment because there's a change in the patient's current status. So you have to go back to your airway and reassess it and continue from A, B, C, D, E. So what this does is it prevents your patient from deteriorating from more rapid causes, and it buys you time to find the problem and manage it accordingly. Okay? Right. So your airway, the most simple way to assess a patient's airway is talking to them. So when you talk to a patient and they talk back to you, it means that their airway is patent. So that it is as simple as that. Something I want to mention amidst all this is this structure is very, very important, because if anyone is giving any interviews in the NHS, there is going to be one clinical scenario. And whatever scenario it is, when they ask you how you're going to manage the patient, they expect you to give your A to E structure of assessing and managing a patient. Okay, so I request that, if regardless of anything you take away from the day, just remembering what your A to E is and how you can tailor it to assessing your patients. I think that that's the most important bit of this my session today. So airway, like I said, if someone's talking to you, then their airway is patent. If they're not talking, if they're unconscious, for example, you can listen to some sounds. Is there any gurgling sounds? Is there a stridor? Is the chest silent? Are you able to feel anything? Is there an obstruction? Is there a visible obstruction that you can remove? So that is in your airway. Some things you can do if your airway is compromised. The most important bit is reposition your patient. So make sure your patient is lying flat and you put them in a head tilt chin lift position. Another maneuver you can do is your jaw thrust. But remember, two things. One, you might be the only person in there who's managing the patient. And two, doing a jaw thrust can be really tiring. Your hand starts cramping after a few minutes and you won't be able to maintain their airway in the long run. So in that case, the next thing you can do is use airway adjuncts. So you have your nasopharyngeal airways, your oropharyngeal airways that you can use. So if you put those in, it'll it will maintain that airway for you. If there's a visible obstruction due to secretions or bleeding, and if you can suction it, that would also help to clear the airway. But remember, only suction the areas that you can see. So don't go too deep in, don't suction areas that you can't see. It's going to do more harm than good. And if someone's airway is compromised, immediately call for help. It's as simple as shout for help, press the emergency button, or if you have to run and ask someone else, or you have to dial 2222. Because if someone has a compromised airway, there's no way you can manage them on your own. Okay, so always call for help. Moving on to B, your breathing. So some things you check in your breathing is your respiratory rate. Just a fun fact, respiratory rate is one of the most commonly miscalculated vital signs. So for example, if someone's counting your respiratory rate and I'm just sitting here and you say to me, oh, I'm going to count your respiratory rate. It's an unconscious thing where I change my respiratory rate. I might slow it down. It might go faster. Or for example, if someone else is counting the respiratory rate and you start talking to the patient, it's going to change it. So it's one of the most miscalculated vital signs. Okay. Other things you assess is your depth of breathing. Are they breathing very shallow? Are they taking very deep breaths? Is there asymmetry in their breathing? Is there unequal chest rise? You can put a SAT probe if you have access to it and check your oxygen saturations. You can auscultate the chest. Is there any added sounds? Is there a new wheeze, any crackles? Is there any absent breath sounds? You can't hear anything. You can even percuss the chest. Is it dull to percussion, normal, hyperresonant? So this examination of your breathing. And again, immediate actions. For example, if someone's saturation is low or they're looking blue, if you suspect hypoxia, please give oxygen immediately. And in unwell patients, we recommend that you start with 15 liters of non-rebreather mask high flow oxygen. Okay. There is a question of what if someone is COPD. if you know that someone is a retainer and they are known to have COPD, you can titrate the oxygens, but a small amount of time of giving high flow oxygen till you reach that. If it's a new patient and you don't know their COPD and you give them a few minutes of high flow oxygen, it would not do a lot of harm in the long run. Okay. And another thing is the new guidelines with ACS says that you do not give more oxygen. You just maintain the saturations between 94 to 98%. So again, in ACS, if you're suspecting a patient with ACS, you can start with lower oxygen, or you can give a higher oxygen and slowly titrate it if they don't require it, or stop it. Another thing you can do an intervention is giving nebulizers, especially for your patients with asthma or COPD. You can hear obvious wheezing. Nebulizers would really help ease their symptoms. A maneuver that really helps with patients with difficulty in breathing is to sit them up. A lot of patients do ask if they can be sit up. It is helpful in a lot of cases, but what I would suggest is please keep in mind that if your patient's hypotensive, their their blood pressure is going to crash if you sit them up. So moving their legs up as well in a V position, it's very uncomfortable, but it is what you can do in the meantime. Or if you can convince them to lie in a more 45-degree angle, 30 to 45-degree angle would really help. And again, if they're rapidly deteriorating, please escalate. One very important thing in the NHS is if you're not signed off or you're not confident to do anything, please don't do it. So you call for help and you wait for someone who's more confident or qualified to do the maneuvers, and otherwise you're going to do more harm than good. Okay. Your circulation, so observing the skin color, is the person pale? You can check the temperature and see. Some of them like to check the temperature in E, but you can also do it in C. And checking a cap refill time, it gives you a good idea of peripheral perfusion. And please remember, if peripherally the cap refill is very high, then go for your central cap refill, because if someone is having, if someone's in shock, they shut down peripherally first. So if the cap refill is relatively maintained centrally, then you have a bit more time to manage the patient, and it does give you a lot of clue. Other vital signs you can check is your blood pressure, your heart rate, the quality of your pulse, and if someone has a low blood pressure, these three things are very important to consider. Is the patient bleeding somewhere? Or is the patient dehydrated? Or is this a response to sepsis? If someone's dehydrated or septic, it's a good idea to give fluid boluses. But in bleeding, very, very important thing is do not give a lot of fluid to resuscitate these patients, because you're going to activate the triangle of death. That is your hypertension, acidosis, and your hypercoagulability. So if someone's bleeding, doing your bolus fluid and asking for immediate bloods is the best way to go, right? Some things you can do when you're doing your circulation is gain IV access. If someone is very unwell, the recommendation is 2 wide-bore cannulas, at least a green cannula, if possible, gray cannulas, both arms. Go for your bigger vessels above your elbow, and start fluids immediately. And while you've done your IV access, please collect the blood and send it for doing your routines, your FBCs, your USNEs, lactate, your group and save if you think that a patient's bleeding. So whatever blood you might need, if you're thinking PE, your D-dimer. So these are some things that you can do immediately, because remember, it's going to take at least an hour for your bloods to come back. Okay. And MHP stands for Major Hemorrhage Protocol. Like I said, if someone is bleeding and you give a lot of fluids, you are diluting their blood, which would cause more harm than good. So you can activate something called a major hemorrhage protocol. Each trust has their own number, and you can ask about it in your inductions, but essentially what it is a bleep number directly. It's a 24-hour line to the blood bank, and when you ask for major hemorrhage protocol, they have a pack of 4 packs of full blood, your packed blood cells, and there are either O positive or O negative. So only women in childbearing age group would get your O negative blood. Rest, everyone gets the O positive blood. And along with that, you have your FFP 2 packs as well. So when you activate your major hemorrhage protocol, generally within 15 minutes, you get your blood to the patient bedside, and you can start bolusing blood and managing the bleeding and hypertension. Next is disability. So a quick way to assess is your ACFU. So if a patient's alert, confused, are they unconscious and only opening their eyes to verbal commands, or only to pain, or if they're unresponsive, it's very, very quick. If you have more time, then you can go for your GCS. Again, checking your blood glucose is a very, very important step, because a lot of conditions, your blood pressure, your blood glucose levels might be low or high, and just correcting that blood glucose levels really improves your patients. If the blood glucose level is low, giving glucose, or if it is high, doing a ketone and thinking about, is the patient having DKA or HHS? So it gives a very good clue if someone is has decreased consciousness. Blood glucose is a key factor in helping us decide if that's the problem. Okay, and it's a very quick fix. Other things you can check is the pupils. Are the pupils equal? Are they reactive to light? Are they unequal, blown, pinpoint? And also, is the patient able to move all their legs, their arms? Is the limb movement fine? Is the power fine? So all these tests you can do in the disability. If someone has a low GCS of 8 or below, something you need to remember is they might not be able to maintain their own airway. So at this point, you have to think about, do they need to be intubated to help with maintaining their airway? And if so, please call for help earlier. Finally, exposure. So it is recommended to fully expose your patients, but please keep in mind that you have to maintain their dignity. So if you need to look at the chest, please expose the chest, but keep the other areas covered. And when you're done examining, please cover it back up and do your examination in portions. Please don't strip your patient and keep them on the bed. It's very unprofessional. Unless they're hypothermic, they're drowned and their clothes are wet and they need to, that's the only situation where you would remove all their clothes and wipe them dry, and again, cover them up immediately as soon as possible. In E, you also do your abdominal examination, and that gives you a lot of clue as well. So if someone's unwell, no bowel sounds, think about bowel obstruction. If there's pain somewhere in the abdomen, think about acute abdomen. Do they need immediate surgery? Also, if someone comes with hematemesis, then it's required to do a perectal examination to check for melena, and also doing your genital region examinations in your exposure. Please, 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 if your patient's awake, take consent and make sure you have a chaperone after you speak to your patient when you're doing these examinations. And like I said, you need to prevent hypothermia in exposure. Some other things you check is, do they have any rashes? If they're having difficulty in breathing and there's a rash, you would think in terms of, is the patient going into an anaphylaxis, or if they have reduced level of consciousness, high fever, seizures, and you see rashes, you can think about meningitis. If someone's, like I said, if someone's bleeding, your PR examination or the site of bleeding is very important. And if they've undergone surgery or they have suffered any wounds, then checking these sites would be very, very beneficial to come to a conclusion of what is happening. So for example, if you see the surgical site and you see it's infected, then you know the cause of sepsis in the patient. Or if they have just had a burn injury, then exposing them would give you an idea of the percentage of burn in the patient. So after we've covered the A to E, essentially we have examined the patient from top to bottom, and we have all the information we would require to manage the patient. In the meantime, like I said, if someone's very unwell, please make sure that you ask for help. And what benefit that would have is, while you're doing your assessment, someone will be able to go through the patient's notes, and that will give you more ideas. Or you can do brief history taking while you're examining the patient, if they're well enough to give you answers, so you have more idea about your differentials. So these are just some things that you can think about. Right. Like I said, blood takes a lot of time to come back. So thinking about what you can get quickly to get more answers. So doing your VBG and ABG, you get the blood in that prick for your VBG, or if someone can quickly do an ABG, if they're very they have respiratory issues. You can see a lot of things. For example, your pH. Are they retaining? Do they need an IV? Do they need oxygen? Are they hypoxic? What kind of acidosis or alkalosis is this? It also gives you the lactate levels for your sepsis. There are electrolyte levels in there, so you can check if they are hyponatremic, hyperkalemic, hypokalemic, correcting your electrolytes through that. Also, your hemoglobin levels are on your VBG and ABG as well. So it would clue you in as to if someone's bleeding internally, if they have an abdominal pain post-surgery. With dropping of hemoglobin, you can think about post-op bleeding. So it gives you a lot of clue. There are also point-of-care testing kits throughout the hospital for things like your glucose levels, your ketone levels. So it's really, really quick. Also, you can do a 12-lead ECG. It gives you a lot of ideas, especially if patient's tachycardic or complaining of chest pain. You can do a urine dip, because remember, the most common sources of sepsis is your chest and your urine. So doing a bedside chest X-ray if someone has breathing issues, to rule out tamponade, or doing your urine dip to rule out any infection in the urine is very, very beneficial. Also, a bedside ultrasound is a more acquired skill, but point-of-care ultrasound is very up and coming now, and it's very, very helpful in medical emergencies. So this is also something that can be very quickly done and gives you a lot of idea on how to manage your patients. Right, I've talked a lot, so we're going to do another quiz. Right, so why do we follow an A to E structure? There's a timer now, everyone, so it's going to stop in now. Right, so I know that everyone's listening to me. You do an A2 assessment to ensure that all life-threatening issues are identified and managed in priority order. Next, yeah. Oh, we have a leaderboard, by the way, so we'll know who's quickest and has answered the most correct questions by the end of it. Right, a patient has a respiratory rate of 32 and saturations of 86% on room air. What is the most immediate action you would do? check in 5 minutes, apply high flow oxygen and assess, prepare for intubation, or call the physiotherapist. Perfect. So if someone has low sats, immediately apply high flow oxygen and assess to see if it's helping. If the oxygen you're giving is not helping, then you can think about higher methods such as non-invasive ventilation, or if that's not helping or is contraindicated, then you have to think about ventilating the patients. You are called to review a patient who's drowsy with a respiratory rate of 8 and a noisy gurgling sound while breathing. What is your immediate priority? Administer IV fluids, administer naloxone, reposition airway and suction, or take a full blood panel. Perfect. So if someone has so your gurgling sound means that there's a problem in your airway, there's an obstruction somewhere, they have low respiratory rate, and if someone's drowsy, it's very likely that the GCS is low. So thinking about, are they able to maintain their airway? And so repositioning, airway management, maneuvering, doing your adjuncts, and if required, ventilating the patient is very, very important. And suctioning can be helpful, especially for gurgling sounds, if there's something stuck in your throat. Secretions, bleeding in that area would help. At what stage would you check a patient's blood glucose levels? Airway, breathing, disability, or exposure? So, like I said, some people prefer doing a blood's VBG, and if it comes back very, very quickly while you're still in your circulation, which is why I haven't put it as an option, you can find your blood glucose levels in your VBG or ABG. But if you have not done that, then please don't forget to do your blood glucose levels and your disability, because a lot of the times the patients have decreased level of consciousness because of low glucose levels. Which of the following is a part of the circulation assessment? Cap refill time, blood pressure, respiratory rate, heart rate, pupils. Multiple answers can be right. Perfect. So you do your cap refill, blood pressure, and your heart rate in your circulation assessment. It's very, very important. Please don't skip these three. And again, a reminder, if your peripheral cap refill is high, then please do a central cap refill as well. The A2E assessment is only for cardiac arrest situations. True or false? Perfect. So your cardiac arrest, your A2E assessment can be done for any patient who's unwell. It does not have to be a peri-arrest situation. Cardiac arrest has its own different algorithm, which we would not be discussing today. But your A2E assessment is, remember, alive patients is A2E. So A, airway, B, breathing, C, circulation, D, disability, and E, exposure for every patient who's unwell, so that you don't miss a single system while assessing them. Which of the following would you do during the exposure step? Check for rashes, assess limb temperature, look at surgical wounds, check for signs of infection. Again, there can be multiple right answers. The answer is all of the above. So in exposure, you have to do all these things. Please check for rashes. Please expose the patient properly. Look from top to bottom everywhere. You can miss something as simple as a small insect bite that might cause cellulitis. So checking for rashes, limb temperature, is the limb viable is very, very important. Or if it's hotter, think about is there an underlying DVT which is causing respiratory problems of PE? If there is a post-op patient, they have a surgical wound, is it doing okay? And are there any other signs of infections? Is a very, very important step of exposure. Right, so who is C? Anyways, congratulations, you're the fastest and you answered all the questions correctly. Right, so let's move on to the next topic, that's Martha's Rule. So have anyone of you heard of Martha's Rule? Okay. So a little backstory, it's a very sad story, but Martha, she was an 11-year-old girl who was admitted when she fell off her bicycle and she had abdominal pain. So when she fell off the bicycle, she sustained injuries to her pancreas and she was admitted in the hospital, and the team that were managing them, because there are a lot of factors that affect patient management, okay? It's not just a person's expertise. You can be the best doctor in the world, but sometimes there are other things that affect how you manage a patient. For example, let's say you were not feeling very well that day, or you had a lot of things on your mind, or there was a lot of disturbances around, or you looked at the wrong notes, or someone relayed improper information to you. So there can be a lot of external factors that influence how you see the patient. So unfortunately for Martha, she became very unwell while in the hospital, and she wasn't getting better, and they were suspecting sepsis, so they managed her with antibiotics. They did the whole sepsis 6. They were doing everything, but the mother kept saying that Martha's not doing okay. The medical team kept saying that we're doing everything as per protocols. She's fine, she'll be better, and she did not get better. Okay. Firstly, there was a delay in identifying sepsis. Secondly, even though you have done an intervention, it is very important to follow it up. But because it was during the bank holidays period, and it was a long weekend, there was a change in the team, which is why the plan was miscommunicated. And so they did not follow her up as properly as they were supposed to. And unfortunately, she deteriorated, she went into multi-organ failure, and she passed away. So in memory of Martha, her parents fought, and they have put in something called Martha's Rule. It says that if you're worried about a patient, regardless of who you are, it can be the patient themselves, it can be the family members, it can be the nurses in the ward, it can be anyone walking by and they see that someone's not doing as well as you would, they don't look right. Or it can be junior doctors, okay? So what you can do is you can activate Martha's Rule. Like I said, it allows anyone to request an urgent review, and who this review goes to is your critical care outreach team, your CCOT. So critical care outreach team is a special team that is a part of intensive care unit, and these are specialized trained nurses that are very good at reviewing unwell patients. So they are very unbiased, external, fresh pair of eyes that can be requested to come and review your patient. Because sometimes when you see a patient every day, you might miss some things, and it's human error. So it's just another step that is kept in place to prevent this, right? So another important thing why I mentioned Martha's Rule is sometimes when a senior clinician explains uh, a management plan for your patient, but you're not satisfied, but you don't feel empowered enough to question their judgment, what you can do is you can request for the CCOT team to review your patient, and it can be anonymous. So it's another step to make sure that your patient is safe. So this is a patient safety initiative that has come into place in a lot of hospitals throughout the NHS. Hopefully, in the near future, it'll be activated throughout the NHS, and hopefully the message goes through and spreads throughout the world. So in country like ours in Nepal, where we don't have a critical care outreach team or Martha's Rule, I really request you to please listen to your patient and their families, because they are the ones that know the patient best. So in our eyes, clinically, we might think that a patient's improving, but there can be subtle changes in their health that the patient or the family identifies before we do, and that could save the patient's life. Okay, so that's all about Martha's Rule. Now I have a little question for all of you. I'm pretty sure that all of you have managed a deteriorating patient, and we've provided you with another tool to help you. So if you see a patient next time, what would you do differently while managing a deteriorating patient? It can be anything. Yes, you can do your A2E. Active listening is very important, not just to the patient, the families, but also your colleagues, because sometimes someone else sees what you have missed. Listen to others' views and concerns as well. Call for help if in doubt. Very good. Escalate when unsure or need assistance. Using A2E protocol, activate Martha's Rule, active listening. Documentation is also very important. Right. So whoever wrote this has just stolen my idea, because this is where I was heading to. What you all have just done is reflected on how you've been practicing and what you could change in the future. So this is another concept that I would like to introduce you all to today. If you're working in the NHS, your portfolio, your revalidation, your appraisals, everything you do requires a reflection on your part. So what this reflection means is you think about what you've learned, what you've experienced, and what you can do differently to improve how you do things. Okay, so The reflective practice in clinical care encourages continuous learning from real patient encounters. Again, it does not necessarily need to be a real patient encounter. It can be something like we did today, where we introduced a new concept to everyone, and you thought about how you can apply it to your practice later on. Okay, and you can also do a retrospective analysis of something that happened years ago that's still, it's some experiences just go in your head. So you can use this reflective practice to think about that as well. So think about things that went well, things that did not go as well as you thought it could have, and you could improve. What reflective practice really does is it builds clinical confidence and resilience, and it really supports safe patient-centered care. And it is essential for your revalidation and professional development. So whenever you need to claim CPD points for anything you've attended, you need to reflect on what you've learned. Otherwise, it's just a waste of your time. I am a very strong advocate of adult learning, and we're all adults now, and we don't have to be prompted to go to classes, give exams, to make sure that we've understood. So we've become very curious in our own fields, which is why I think reflective practice really helps you flourish in whatever field you want to go into. So Gibbs' reflective cycle was introduced back in 1880, and it is still very actively in use. And it's a very interesting way to reflect on anything that has happened. So you can use this method if you want to write a reflective piece later on, okay? So there's 6 steps to the Gibbs reflective cycle. The first is description. So ask yourself, what happened? What was the situation? Then you think about what were you feeling or what were you thinking when that happened. Then you can evaluate the good and bad about the experience. After that, you analyze, why did things go well, or why did things did not go as you planned, okay? And in conclusion, you can say, what could you have done differently? Or you can also think, what can you carry on from this experience that you have done well to keep doing well in the future, okay? And then you create an action plan for yourself. So what will you do next time when you're given a similar scenario? So in context of today's topic, your A2A assessment, I hope everyone puts in their action plan that next time you assess an unwell patient, you do your A2A assessment. And also, please, if you're giving your interviews, this is the best tip I can give you. If it's a clinical scenario, answer in your A2E manner. That is the best way you can answer a clinical situation. Okay? Right. So the Q&A is open now. If anyone has any questions, they can put it up here or in the chat box, and I'm very happy to answer. Or you can unmute yourselves and ask questions if that's something you're more comfortable with. But if I request that if you want to unmute yourself, please turn your videos on so that I know who I'm speaking to, okay?
I think Sagarika, that's really well done.
Thank you,
I
Mr.
think it's one of the very good example of how to present in online forum. That was quite captivating and engaging. Well done.
Thank you very much.
Now, while
I hope I answered your question.
yeah, you did. But having said that, there are very quite few important person who has joined our this online forum. We have Mr. Kamal Aryal, Dr. Kamal Aryal, who was a past president of ND UK. He's a clinical lead in Great Yarmouth Hospital, and he's currently doing robotic surgery and colorectal surgery. So he's quite an important person. He does conduct a lot of courses in Nepal, and he has been helping India, UK quite a lot. Dr. Kamal.
Thank you, Assis and team. So I'm sorry I couldn't join in earlier. I'm on call this weekend, but I've done my ward round and I saw this message, and how could I miss it? So it is great to see NDA UK flourishing. I can see more than 45 people here, which is great with great themes. So I know you already have done few sessions. So I look the success and I look forward to seeing them, many of these in the future, so that our community and our education flourishes in the future. Thank you very much for doing it. Wonderful presentation, the one I just listened. Thank you, Sagarika. Yeah.
Thank you very much. I have a question from Sam. She's asked if I could explain a little bit more about simulation-based learning and what way it could be introduced to Nepal. So simulation-based learning can be, it's a virtual environment that you create to practice anything, okay? So it can be something as simple as role play. So it can be two people who are sitting together. One person acts like a patient and you practice your history taking with them. So it can be a very useful tool for your exams. It can be mannequin based, so it can be a simple arm mannequin that helps you take blood. So if you want to practice venipuncture and you don't want to do it on the patient first, or you want to learn the proper steps and techniques of doing something as simple as a cannulation or putting a catheter in, is your more simpler versions of simulation. There is more high fidelity simulation as well, where you go into clinical areas and you simulate, for example, you put a mannequin there, or even a person who's acting to be a patient who just collapses on the floor, and you watch how they manage the patient. And it's a very good tool to pick out where mistakes were made so that people can learn in the future. Okay, or you have your expensive mannequins like a SimMan that you use for your PLAB 2 exams, your PACES exams. It's like an actual patient. It breathes. You can create different sounds. You can paint on it, make it look different. So that's just a brief overview of what simulation is. It's a very, very vast topic. I can go on and on. But it's an excellent way of learning. Introduction in Nepal. Mr. Shrestha has recently broached this topic with me, actually. And the thing with simulation in Nepal is, one, it's costly, because you need mannequins if you want to practice your clinical skills. So it'll take a few years for us to be able to advocate how much that is necessary before everything is, in action here. We already have a sim center in Thapatali where they teach BLS and ALS. We also have a simulation center in Hams Hospital for, I think they had some obstetric and anesthetic training, if I'm not wrong. So I'm working on it. All of us are working on it. The NDA is very, very interested in bringing simulation to Nepal. So when we have more updates, then we'll put it up. And it would be very helpful if any of you have any ideas on how we can get that up and running. It would be great. Kemi, yes, Mr. Shrestha?
I think Sagarika, I think that's something we want. That's a future project of NDA UK. And
Yeah.
we are in touch with people in Nepal, and with the help of Sagarika, who's done a simulation fellow. She's done it for more than a year, am I right? And it's quite a task she has taken. Well done, Sagarika. I think we are planning to introduce that in Nepal. I think we might have to go to the government level to so that they can be introduced in the curriculum. Yes, Dr. Kamal.
No, thank you, Sagarika. So I think I just saw a comment on the chat that we have got a simulation center at Bir Hospital. It is a huge project. WHO, then the ANMF, NDA UK, Health Access Nepal, all were involved. and I had a chance to visit the place a couple of times, but I have not conducted any simulation session there. I did want sort of lecture-based teaching, but I think that's a big center there as well. In addition, at the Likhel, we do quite a bit of courses as well. So there are many centers coming up. Development is there, but we just need to utilize it more efficiently. I suppose that is all I would say.
So my vision is it rather than people from outside visiting and running courses, I really want to train faculty in Nepal who can run simulation regularly, and it can just shape the way we teach completely. It would be wonderful.
Absolutely, yeah. So local need to take the lead at this. Yeah.
Yes,
Initially,
yes.
the outside people may come and help to establish, but the local people need to take the lead, of course.
Yes. So my role would be to help train people in simulation so that they can start running the courses and utilize the wonderful sim center that we have in Nepal. Right. Kemi wanted to ask about major hemorrhage protocol. So if someone has very active bleeding that makes them hemodynamically unstable, in such cases, rather than giving a lot of fluid boluses and hemodiluting them, it is advised to start blood transfusion as soon as possible. But like we know, taking bloods, blood grouping, cross matching, group and save, it takes a lot of time. So major hemorrhage protocol is something that has been developed to overcome this barrier. It's a number that you can dial. It's different in various trusts, and you just dial that number. It puts you directly to a 24-hour service of your blood bank, and you can get either O positive or O negative blood, 4 packs, and your fresh frozen plasma, 2 packs. Only women of childbearing age get O negative blood because it's very, very rare. And this is to prevent erythroblastosis fetalis. Rest, all of the population would get O positive blood. And we can start that blood transfusion. And once we have group and save, we can give them the actual blood that they have been cross-matched with. Okay, I hope I answered your question.
I think major hemorrhage protocol is another lecture. If people are interested, we can organize in future. It's quite a broad topic. I think you have summarized it really well. And on the floor, we also have Dr. Parul Shrestha, who is our consultant rheumatologist, and she is a lead in rheumatology currently and has been leading audit in the past. Do you have anything to say, Dr. Parul? No. Okay, we'll introduce her later. But any burning question from the floor? We're bang on time, so 11. Or we can send any question on the chat, and we can answer that later. Sagarika, do you want to introduce another speaker?
Yes, the next speaker we have is Simosh and Alka. They're going to speak a little more about your early warning scores, your new scores. I would like them to introduce themselves more thoroughly, please, in case I miss anything. And in the meantime, if anyone has any questions, I'll be answering in the chat box. Thank you very much.
Hello everyone, I'm hoping that you can see me. Good morning to the people in the UK, and afternoon or good night to everyone else in the world. I'd like Samosh to put his PowerPoint on if he can. Yes. thank you. So me and Samosh, we're actually both IMGs as well. We both studied abroad in Bulgaria, so we're, you know, quite familiar to the cultural differences that we've had to adapt to in the UK, as well as different medical jargon and different scores that we've had to become accustomed to as well, because this is something we don't have abroad. So we will be starting on early warning scores and implementing levels of escalation according to those scores. Next slide, please. So why is this important? Evidence actually found previously that there were actually delays in recognizing deterioration in patients. So a score or something universal between, you know, all the staff, all the hospitals in the NHS was needed to prioritize these patients, as we know, patient safety is our top priority. So the NHS uses a structured escalation pathway that I'll speak more about in the next couple of slides, and a team-based approach. So even this scoring system involves a team-based approach where if, you know, the score requires a certain level of escalation, certain members of staff certain members are informed. Clear communication is also emphasized during the use of these scoring systems as well, like the S-bar, I'm sure some of you have heard of, which is quite often used at the NHS as well. IMG challenges that you may face while using these type of scoring systems is that they wouldn't be used overseas. Like, for example, I know some of you are from Nepal, some of you, you know, are from Bulgaria. But here in the NHS, we use the news score that's encouraged and is actually expected as the standard for safe practice. So cultural differences might mean that early escalation is, you know, maybe not quite held an importance of, but here it's actually quite important, and you're encouraged to escalate early to your seniors just for the safety of your patient and your own safety as well. So the News 2 is validated across the NHS. So even if you're working in a small hospital in the UK or in a large teaching hospital, when you say the news score, the staff should understand what you're speaking about. It's a universal language and standardized across the whole of the UK. Also, if you're from anywhere else in the world, please comment in the chat, you know, any scoring systems that you use specifically there, just so, you know, we can know each other a little bit better as well. Next slide, please. Okay, so the National Early Warning Score, the News 2 as it's now known as, was launched in 2012 actually, and like I said, there was evidence that said, you know, early deterioration of patients wasn't actually caught as quickly as we wanted to, leading to, you know, unwanted emergencies or a deterioration in patient outcomes. So it was a response to a number of national inquiries into patient deaths in hospitals, identifying the need for early detection to improve patient outcomes. And like I've said, it's national, so it's across the whole of the UK. It's one single system. You're taught this in med school as well, to use the news score, and everyone is using the same language. They understand what it means. It's based on 6 basic physiological parameters, 6 vitals, being the pulse rate, blood pressure, respiratory rate, oxygen levels, temperature, conscious level, or new confusion that's been caught as well. Next slide, please. Thank you. So as you can see here, this is a chart explaining to you, you know, the physiological parameters. You'll notice that there are 2 extra boxes than what I've said to you before. And this is for the 2 scales of oxygen saturations. The first one being what you would use for normal patients or everyone else. And the second scale specifically used for patients who have a lower target for oxygen saturations. For example, patients with COPD, patients who have CO2 retention. Respiration rate is at the top, and you'll see the score ranges from 0 to 3 for each parameter. So that's how we would score it. For example, a respiratory rate of around 10 would score you 1. A respiratory rate of around 23 would score you 2. So however much the value deviates from the norm is how far the range would be. For the saturation of oxygen, like I said, it differs between normal patients and patients with different targets or different expected oxygen saturations. If you have a value of around 93, for a normal patient, it would be a 2, but for a patient with, for example, lower expected oxygen saturation, a value of 93 would score a 1. We'll move on to systolic blood pressure. I'll come back to air and oxygen afterwards. Systolic blood pressure gives you a range of 111 to 219, which is something you should be careful of because 219 is a bit on the high end. Pulse per minute, you have 51 to 90 being your norm, and however much it deviates is the score. So less than 40 would be around 3. And over 91 would be 1, over 111 would be 2. Consciousness, you've got, if they're alert, they score 0. CVPU scale, they would get a 3. And for temperature, the normal range being 36.1 to 38. And if it deviates lower to 35.1, you'd give a 1. Less than 35 immediately scores a 3. Onto air and oxygen, like I said before. So whatever score you get, you aggregate a total. So for example, respiration rate, we have a 3. Oxygen, we have a 2. That would be a 5, and you carry on. At that end, you check if they're on oxygen or not. If they are on supplementary oxygen, then you would immediately add 2 extra points for that. Next slide, please. Thank you. So now that we know how to total the news score, moving on to understanding the news score. So if they score a range from around 0 to 4, this is deemed as being low clinical risk, and the response would be from a competent registered nurse or equivalent on the wards. If they, however, score a 3 in a single parameter, this leads to actually a medium clinical risk because it's quite significant, and you would have to have urgent review by a ward-based doctor instead. A range of 5 to 6 would give you medium clinical risk as well, with a frequency of monitoring of a minimum of every hour, and this is by an urgent review by a ward-based doctor or acute team nurse. A score of over 7 is deemed high clinical risk and very significant. You'd need to have continuous monitoring of vital signs and a quick assessment, emergency assessment by a clinical team or a clinical care team as well. And they'd have to be transferred to an ICU, a higher level of care. Next slide, please. So the escalation pathway, as I kind of mentioned previously, it's a stepwise approach as usual in the NHS. You would start with your nurse, then your junior doctor, your registrar, your specialty registrar, your consultant, a clinical care outreach team if you reach the higher, medium to high clinical risk side. And for unresponsive patients, peri-arrest or arrest situations, the crash team would be called immediately as well. Next slide, please. So when you're feeding back the news score to a senior or whoever you're escalating to, it's quite important to use the right level of communication. And we use SBAR communication, which I'm just going to touch on briefly, as I believe we'll have another session dedicated to SBAR communication and communication tools that you can use here when you come to the NHS. So your situation is what's currently happening now to the patient. Your background would be any relevant history that you think is important to communicate to the relevant person. Your assessment would be your observations, like Sagarika mentioned, your A to E. Your news score would be implemented here. Your recommendation would be what you need, what you want from the conversation, what you want to happen. A tip that I would give is to write your SBAR on paper before calling, especially as like a foundation doctor and SHO. It makes it quite easy to relay that information as well. Next slide, please. Thank you. I'll be handing over to Samosh now for the next few slides.
Hi guys, can you hear me?
Yes,
Hello?
we can hear you.
Yes, you
Okay.
can.
Hi, I'm Simosh. I'll be taking over these next few slides. Thank you for the presentations by everybody so far. They were really great. So New Score, it's not a perfect tool, obviously. It's a guide, and it's important to correlate the New Score to your own clinical finding and what you feel the patient is presenting with. Always trust your clinical judgment. If you think the patient looks unwell, they probably are. And there are exceptions in New Score. Sometimes it can be high, and the patient might just be presenting with pain. A lot of trauma calls that we get in general surgery, people presenting with rib fractures, might not necessarily require oxygenation, even if they're tachycardic or tachypneic, or they might not require antibiotics, as the guideline suggests. The NICE guideline currently says anyone that scores a New Score of above 5 and you suspect sepsis need to administer antibiotics broad spectrum within 60 minutes of their first observation. But this might not imply on everyone that's scoring above a News 5. And some people might score low, even if they're, clinically unwell, because a lot of patient that presents to surgery that might be having PR bleed, they might not actually be scoring that high in their news, even if even in reality, actually they're losing a lot of blood and they need urgent treatment. They might not be scoring high. So it's important to correlate this into your actual findings. So don't use it as a singular tool, but as a guide to your judgment. So the things the news score can easily miss is things like early stages of sepsis, ACS, acute coronary syndrome, things such as pulmonary embolism, anaphylaxis, and like I said, GI bleeds. The news score might not be as accurate. But the red flag symptoms always to look out for when assessing a patient is always new or acute onset confusion, increasing oxygen requirement, hypotension, clamminess, mottling of the skin, severe breathlessness and chest pain, and reduced urine output. These are the signs to always look out for. So things to remember: escalation is always encouraged. Okay, so you might feel like when you start, like when I started my first shift, actually in the NHS was a night shift, and I was covering surgery as well as ENT cross cover during the night. So it was a very daunting experience for me to be starting off like that. But I found very quickly that you have a lot of support around you. My registrar was highly supportive, and I could always go back to him. And escalation is always encouraged. So there's always people around you, always seniors around you who are ready to help you. So you're not alone when you're managing this patient. You should not feel anxious. Even if you do, you have support, enough support. And like my colleague touched upon, you have specialized team like the critical care outreach team, who are specialized nurses that have a lot of experience in managing really unwell patient in the ITU. And they're super helpful. You call them and they'll actually be there, sometimes even before you, and have already assessed the patient. So do not feel scared. You have a lot of support. And the importance of documenting clearly. Cannot stress this enough. You need to be documenting everything that you do on the patient. So even if it's a brief conversation with a nurse, or the next of kin, or the patient himself, This is just to ensure clear communication between teams, because once you hand over, you never know what has been covered, what has been discussed with the patient. So this is for your own protection as well as the team that's going to come after you and take over, so that they have a clear understanding of what has been discussed, what has been done. So it's very important to document everything clearly. So be prepared to anticipate questions. Like my colleague said, it's important to just have just basics down, at least, write it down as an ASPAR handover. If you feel like you're going to be, stuck on something, just write everything down before you make the call to your senior. And because obviously they're going to be very busy as well. And if you don't provide clear information, it can delay treatment. It can delay the review that the patient needs. And it might not, make your registrar feel like, okay, this patient's that unwell. So have everything prepared before you make the call, so that you don't repeat yourself or miss out key information. And know your sepsis pathway. So the big six of sepsis, you need to have that like almost ingrained into your head: oxygen, antibiotics, fluids, and 3 outs: bloods, lactate, and your urine output. So these things needs to be like in the back of your head at all times, especially with patients scoring high news. You need to have that back in your mind. Sepsis is something that kills a lot of people every day. So this is something that needs to be enforced. So teamwork and communication, there's always a hierarchy, like my colleague again said. So the nurses will obviously be the ones that are going to be taking care of the patient the most. Once they feel like, they also go up off the news score. So if they feel like, this patient is doing unwell, they're scoring high news, they'll escalate to you. And you as in, I don't know how many of us are here are registrars. I'm personally myself an SHO, so I appreciate that there are doctors in this forum who are, consultants and registrars themselves. So this is just on a very foundational level. So they would escalate to you. There's a clear hierarchy, and then you need to follow that. And there's always support in every step of the way. So always ask for help early. If you're expected to involve seniors and not manage the patient alone, so just before you, even if you feel like, someone's called you to see a sick patient and you feel like this is something that's beyond your control, then you should let your registrar know very early on the way that you go to see the patient. Let them know, okay, this is a patient that I'm worried about. Could you please come support me? And they'll be more than happy to do it. So I'm going to be going through a few case scenarios with you guys. You can use a chat function to reply. If I had known about Slido, I would have probably used that too, like my colleague Sagarika did. That was really good. But unfortunately, this time around, I'll just be using the chat function. So first case scenario, Mr. Smith is a 72-year-old man who's come into the emergency department with a background of COPD. He's got worsening shortness of breath, productive cough, and a fever. And these are his observation initially. So I've put the score that it would give with each and every parameter, and this would aggregate to give you a score of 12. This is a high-risk patient. So what would your steps be here? A to E, yep. Sepsis 6, brilliant. Okay, so after you've done your A2E assessment, you provide them to this person is tachypneic. He's not saturating very well. He's got a slight fever. His tachycardic and his systolic blood pressure is 96, which is pretty low. So on this patient, A2 assessment would already, mitigate most of these things. So once you go through that thorough A2E assessment, you'd, fix everything on the way. So you'd give oxygen, you'd give IV fluids, you'd give any analgesia, see if they're in pain, check their, if there's COPD. So this patient has a background of COPD, so you'd have to give high flow oxygen initially and taper that down so that they don't go into carb retaining. So there's a lot of things that you look into, but the main thing here, you need to escalate this immediately to the medical emergency team and also the critical care outreach team. So this is a patient scoring high, which is very high suspicion of sepsis. You'd also start antibiotics. So always escalate. So this will require a senior review within 30 minutes. So have a clear ASPAR handover, call your registrar, give them the situation, background, and what you've done so far, and please come and review this patient. You're worried about them, and they'll be there. So what are some of the differentials that you're thinking of here? Guys, use the chat function. I'm going to be keeping an eye there. So patient, shortness of breath, productive cough, fever. What are the differentials that you're in the top of your list at this moment? Pneumonia, good. Okay, so I'm just going to move on for the interest of time. Yeah, the main thing you'd be thinking about here with a score of 12, someone coming with productive cough, fever, chest infection is the top priority that you're going to be thinking about. Other things that you can order, given that you're suspecting this, would be a chest x-ray, ABGs, check their actual arterial saturation. This could also very well be a exacerbation of their background of COPD. So make sure that they're on nebulizers, make sure, their saturations are in the correct range. And also this could be pulmonary embolism. So do they have any significant background of heart condition like arrhythmias, or do they have previous history of DVT? How do they score in the Wells score? So all of these things that you need to be in the back of your mind while you're giving the handover to your registrar, so that they have a basis to go off of as well. So you're the first person that's going to be assessing the patient, and everything that you take from the history is very important, and escalation is very, very important. So how quickly should I already answered that? Sorry. So senior review in this patient scoring high of 12, 30 minutes is the maximum time a senior needs to be able to come and review this. What are the priorities? We already discussed that, the sepsis bundle, oxygen, antibiotics, urine output monitoring. Yeah, so sepsis 6 is very important here. At what point is ICU or a ITU referral warranted? So this patient, if you've done all the basics and they're severely still desaturating, if they're still severely acidotic in their ABG, then you need to have the ITU team involved as well. They might need some vasopressors, they might need inotropes, they might need intubation if required. So it's very, very good to get your ITU team involved as well early on, so that they can prepare for them from their side as well, in case this patient deteriorates and needs an ITU referral, ITU admission. Right, I'll move on to the next scenario. Mrs. Patel is a 64-year-old lady. She's 3 days post anterior resection for bowel cancer. She was initially recovering very well, and now she's getting increasingly unwell. So 3-day post-op surgery patient. On the ward, the observation is RESP of 24, saturating 94 on room air. Temperature is 38.2, scoring 1. Heart rate is 125. She's tachycardic. Her systolic is 88. So scores of 3. Consciousness is alert, but she's anxious. She's not requiring any oxygen. So this would give you a new score of 10, which is very high. Again, the nurses has bleeped you, and what would your next steps be? And what are your differentials here? If anyone would like to speak, you can raise your hand too, and you can talk as well, if you're keen. If not, then use the chat function.
I think that's the one way of people can speak. They can one way of communication. It'll be good to communicate with you. Yeah. Anang.
Anang has raised his hand. Go on, Anang.
Anang is our senior registrar at William Harvey Hospital.
I just want to stimulate the discussion. This is a quite unwell patient on post-op day 3. As Sagarika said, most likely most of our colleagues will start with ABCDE and then carry on to the next step of management.
Yep. So urgent escalation to a surgical registrar. So this is a patient who has a high risk day 3 post-op of an anastomotic leak, which is in turn caused sepsis. So this needs an urgent review from your registrar, anesthetic and critical care. So all the team has to be involved in this scenario, especially. So who should be called for is your registrar, anesthetic team, and the critical care. So the point I wanted to emphasize is how is this different from a medical patient is because this is a patient who's post-surgery and he's query a suspected anastomotic leak. So this is not something that's going to be optimized medically. So you need to get a lot more teams involved in this level because this patient might as well be going back to theatres. So you need to get an anesthetic team ready. You need to get the critical care team ready in case they need ITU admission afterwards. So and have a very low threshold for scanning a patient presenting with a new score of 10 who's day 3 post-op. So someone who's undergone a big surgery, there could be the main differential here is an anastomotic leak and intra-abdominal sepsis. Yep, so importance of early imaging so that the surgeons have an idea of what's going on, what needs to be done, the anesthetic team so that they can assess the patient and have them ready for theatres, critical care team if the patient needs admission to ITU afterwards. So this is a very high risk patient as well.
Sagarika has raised their hand.
Sagarika?
Hi, I just wanted to add a little bit on the triggers of new score. So if any patient is scoring or a 3 or in one parameter or more than 5, then regardless of who, generally the first escalating doctor is the doctor in the ward, which is usually a foundation doctor, trust grade doctor. But if a patient is scoring 3 in one parameter or 5 or above, then they need to be reviewed by a registrar level or above within an hour. And any patient scoring a new score of 10 or above is an immediate medical emergency. And also, like Simush said, every patient needs to be escalated within their team first, before you involve an outside team. So there's a hierarchy of escalation.
Yep. Thank you very much, Sagarika.
Good thing is that all the escalation comes to us very last. The consultant comes very last. But sometimes we end up in a situation where we have to respond first on.
Yep. Does anyone else have anything to add on or any questions about this case? Is there one reason? No, that's Sagarika.
I think by speaker asking questions, I'm like enabling people to speak. I think that's what we encourage in here in this forum.
Yeah, yeah. Please feel free to just speak up.
Okay.
Any questions that you have, just.
I can see Samit Shah there. Do you want to ask anything, TJ?
Is this the criteria for urgent return to theatre? So Sagar Bhandari has asked, is this the criteria for urgent return to theatre? So again, day 3 post-op anterior resection, there is a high suspicion for an anastomotic leak. So even if the procedure has gone well, you don't know how they're going to be day 3 post-op, how they're going to recover, how well the anastomosis holds. So we need to, at this stage, me personally, I would get an urgent CT. So you need to talk to your radiologist. You need to get your the scan vetted. So contrast abdomen and pelvis CT to assess the collection. And if the collection is large enough for them to be taken back to theatres, then it needs to happen. So this is a criteria for urgent return to theatre. However, if the collection is not amenable for drainage, then it can be done radiologically as well. So there's a lot of different options, but you need to have all the team prepared, and especially your own registrar and consultant needs to know about this. So this is just emphasizing the importance of escalation. So this is not something you would be able to manage yourself as a foundation doctor. This is something that needs an urgent review by a senior.
Yes, I completely echo with what Semos has said. As a foundation year doctor or a ward doctor who is looking after this unwell patient, I think if I was that doctor, I would think, let me stabilize the patient, let me escalate it to appropriate senior colleagues, and regards whether this patient needs going back to theatre is a decision that can be subsequently made by more senior people. But as a foundation year doctor, I would think of stabilizing the patient, doing all the ABCDEs, giving patient what the patient needs, and then arranging a few investigations that can be done at my level, and then proceed to what my senior colleague would ask me to do. I would wait for their decisions. But in back of my head, I would think, based on my physical examination, where the sepsis is coming from, whether I can find few findings which I can point out or signpost towards my colleague to help them make a decision. That would be my role. I would think that way.
I think this is a good example of understanding your limitation, and that's what we want from people during the interview. You can, when you see any sick patient, you can manage that patient to a certain level, but at some point you need to escalate that to someone else or ask for help. This is a very good example, and we expect you to do the same in the exam. We don't expect you to manage a patient. I'm like know exactly what to do with that patient surgically, but at least you can take it to a level where you can escalate to your senior. That will be really helpful. So that's what we are looking for during the exam or in the interview scenarios.
Yep, that's very important. Yeah, as foundational doctors, you're not expected to do everything by yourself. You're not expected to take this patient to theatres. So like Anang said, you need to, at your level, you need to just stabilize the patient, have all the information ready for your registrar, for the handover, and you just need to get the ball rolling. So, you know, if you want scans done, if you want different teams involved, it's just your responsibility at that level is just to get the ball rolling, get all the team involved. The ultimate decision is obviously going to be at a senior level, but at your level, it's more important just to stabilize a patient and get everything going. And these are questions that are very common in interviews, actually. So yeah, it's very important to know these escalation steps and the steps of stabilizing the patient. So these are questions that are often asked in interviews as well in the NHS. I'll move on to our last case scenario. So you're a foundation doctor in an acute take, and this patient has come in with 55-year-old Mr. Johnson. He's come in with worsening abdominal pain, nausea and fever, and his past medical history is type 2 diabetes. So his observation in the ED, he's slightly tachypneic, he's saturating well, he's febrile, he's got a heart rate of 110, so slightly tachy. He's got a systolic of 100, so slightly hypertensive. He's very drowsy when not stimulated. So he scores a V in the APView, which is the alert, voice, pain, and unconscious. So he scores a V. And he's not requiring any supplemental oxygen. So this patient, again, scores a 9 in the new score. So let's just open the forum for discussion. What would you do? Who would you escalate to? And what are the things that you would do as a foundation doctor in the ED? So anyone that is keen to answer, please raise your hand or just use the chat.
I can see Bijaya there. Anybody? Bijaya, Nishu.
Samiksha has said A, B, C, D, E. Yep. A, B, C, D is always the main approach when you come across an unwell patient. So always do your A, B, C, D, E. That's true. Okay, I'll just move on and we can have a discussion after. So again, this is a patient who you're suspecting something going on in the abdomen, obviously. So you need to escalate to a senior review. If you're an acute take, then your direct senior would be your medical reg on call, and you'd also need to think about doing a referral to the surgical registrar. So as a surgical registrar, they expect some key information when you do the handover. So always have that prepared. ASPA, write it down on your paper before you do the referral, because sometimes they can ask you very specific questions, like blood findings, lactate, what is the where is the pain, like what is the pain level, where is it localized. A lot of different things can be asked by the surgical registrar before they agree to see the patient. And obviously this is scoring high on a 9, so you need to again do your sepsis 6, make sure they're well saturated, make sure they're started on an antibiotic, because this could very well be a intra-abdominal infection going on in somewhere. Could be a perforated appendix, could be diverticular disease. So you need to have a thorough look through this patient's medical background as well. So there's a lot of investigation work that goes on in a junior level. So you need to have all the information ready. So likely diagnosis here, like I said, if they have a history of diverticular disease, or if they have a history of having gastric ulcers, how are they hemodynamically? He's obviously got a systolic of 100, so he's not perfusing very well. So you need to have all these things in the back of your mind before you do the referral. and always have a very low threshold for scanning a patient, because it's very important for surgeons, especially, to have a CT abdo-pelvis, because that's the gold standard way of identifying any abdominal pathology that might require surgery. So, yeah, discussion point. So, when would you, in this patient, like, when would you involve critical versus surgical team? I think in this patient, both team needs to be contacted at the same time. So this needs a surgical input as well as a critical care input, because this is a patient that very might well be heading towards a surgery. So you need to get them both involved at the same time. Should antibiotics be started before or after imaging? What do you guys think? So on a patient who is scoring a news of 9, before you do the referral, you've got everything noted down, would you start the antibiotics? Exactly, yep. So you start the antibiotics, you don't have to wait for the scan. Broad spectrum, obviously you have to check if the patient is allergic to anything, and start a broad spectrum antibiotics according to your hospital guidelines. This is very important and it's part of the sepsis 6. Role of timely fluid resuscitation and source control. So like I said, this patient is hypertensive, obviously very septic. So it's very important to stabilize the patient, and source control the infection before it spreads. So at a junior level, this is all that is asked of us. Actually, we're not expected to just cure the patient. It's basically we're stabilizing the patient until a senior review can happen. So thank you, guys. If you have any questions about any of the key takeaways, so news 2 is something that is used nationally here in the NHS. It's a universal language of deterioration. It gives you a score. It's a scoring system, gives you an aggregate score that is indicative of how well the patient is doing or how unwell the patient is doing. SBAR is the communication tool that we use here. It's very clear: situation, background, assessment, recommendation. 4 very key information that you need to have, clearly communicated to anyone that you're handing over the patient to. Escalation saves lives. So don't ever think that you can handle this patient by yourself. Any patient that you are unsure of, any patient that you feel this is out of my hands, always escalate. There are multiple teams around you: major hemorrhage protocol team, crash team, arrest team, critical care outreach team. So there's a lot of different specialties that are allocated their own role in the NHS, who will be more than happy to come and review a patient for you. And always trust your clinical judgment. So don't use the news score as a sole indicator. Always, take good history, good anamnesis. Always correlate that news score to your findings. So don't use it as a single tool, single indicator. So always correlate this. So any questions now about news score, any of the cases, or any escalation protocols, then please feel free to ask, and we'll try our best to answer you guys in the chat. Or if you want to speak, then please raise your hand and we'll take questions.
Sorry so much. I'm just gonna add a little
Yep.
brief bit of information about the Pew score, as someone had asked before, for the pediatric early warning score, if that's all right. Mr. Shrestha has kindly in the chat added an image of the Pew score, so if you'd like to refer to that. So the Pew score is for children, for the pediatric population, and it, similarly to the news score, it identifies the early signs of deterioration in children. And the difference between the two would kind of slightly be the parameters that are used in the Pews. It can vary by hospital, but often there's 3 main domains. So like the picture says, this would include behavior, the cardiovascular, and the respiratory. And also for the Pew score, as we all know, in children's population, the age is quite important. So the normal ranges for the Pews is age adjusted. So there's different cutoff points for different age groups. And whilst the next session is happening, I can send a actual large chart that's on the internet about the different cutoff points for different ages for the Pews. So moving on to the domains for the behavior, this is the neurological status. If they're normal, they're playing, they're alert, this gives you 0 points. If they're a bit more, sleepy, less responsive, if they're becoming irritable, this gives you around 1 to 2 points. And then the highest point, which is the 3, would be given if they're drowsy, if they're unresponsive, things like that. For the cardiovascular, like I said, it's the heart rate compared to, the age-adjusted normal range, again, ranging from 0 to 3, the values. You check the capillary refill, if it's over 2 seconds, how their skin is looking, if it's mottled, if the pulses are weak, obviously this would score on the higher end. For the respiratory, this is also according to the age-adjusted norms. You should check their work of breathing. Are they having difficulty? Any chest retractions, nasal flaring, their oxygen requirements as well. And again, like the news, the scores are added up, each domain giving a score from 0 to 3. You give a total score of the sum of all of the domains. And like previously, the higher the number, the more deteriorating the patient has become. So when understanding the scores, 0 to 2 gives you a lower clinical risk, 3 to 4 giving you medium with senior nurse involvement, increasing the observations more frequently, 5 to 6 giving you higher risk with urgent medical review needed with the doctor, and over 7 giving you you needing emergency review. So I would say the key points to remember for this would be, the age-related norms, which is different to the news. A rising Pews is quite significant in, telling you how the patient is doing. And again, the escalation pathway, who to call, how urgently, when to start monitoring, how often to do the monitoring. And yeah, that's all for that one.
We do have Sasakta, who works in a pediatrics unit at Barking. Sasakta, you raised your hand before. Do you want to contribute? I think somebody asked, who is there any pediatrician in the floor? I think Sasakta is the one. Sasakta.
Hello, everyone. Thank you so much for talking in detail about the Pew score, Alga. I just wanted to add, introducing myself first. I'm Sashakta. I'm one of the resident doctors working in pediatrics. I just wanted to add that while the NHS, I think it's actively trying to replace and update the Pews score. So a lot of trusts are actually using National Pews score now. I've sent a link on the chat if anybody is interested. Anybody in PEDS is interested to know what the National Pews score is like. And it has just added on a lot of information. So if anyone's interested, the link is in the chat box. I just wanted to add that.
I think we can open question to the floor. If somebody can come and open the videos. See, like Mr. Ankur Shah said last time, if you speak now, you'll be known. Yeah, open your videos so that we can all see you who's there. And if we meet in person in future, we can know exactly who you are. So any question for Simos or Alka?
Just before we start, I would like to say that Mr. Harinath, a consultant surgeon in William Harvey Hospital, is also in this meeting now. He's joined us.
Hi, everybody. Can you hear me?
Yep, we can hear you very clear.
Thank you.
Simos, do you want to introduce as Dr. Kamal Aryal? Kamal Aryal is also here. they'll be in the consultant forum.
Yeah. So we've got Miss Dr. Shrestha, who is a clinical lead in rheumatology, working in East Kent as well. Her specialty includes, systemic lupus erythematosus, vasculitis, and things like that. And she's a clinical lead, like I said, and also a joint secretary in the NDA UK. Secondly, we've got Mr. Harinath, who is a consultant general surgeon. He completed his medical school in Venkateswara in India. In 1990, he completed his surgical training in South Wales in 2006. He's contributed a lot for the general surgery department in William Harvey, as well as throughout the NHS. He's also a general pediatric surgeon with interest in, a lot of pediatric surgery. So he's also another pediatric surgeon. If you have any questions in that aspect, he can answer. So that being said, I think we'll open the floor for any questions, and we'll get the ball rolling.
Yeah, and we also have Dr. Kamar Adyar. I've already introduced to all of you before. He's quite a prominent surgeon. He's quite prominent in Nepal. He's done so much activities in Nepal that any one of us has done, and he has taken the flag of India UK really well.
Okay, would we like to go around and introduce the consultants? I'd say starting with Dr. Parul Shrestha. She's got her hand raised. Dr. Shrestha?
Oh, I think that might have been from earlier, but I'll just answer. I've put in the chat the answer to one of the questions about fallacies of Muse. So I think people will be able to see. So Muse is not foolproof, and it is always the clinical acumen, because some patients, then the Muse score will be normal, but they're at point of crashing. So it is the clinical acumen, which is very important. And we see that a lot in medicine as well. So that's what I wanted to say. You want me to introduce myself?
Yep, that would be great, Dr. Shrestha.
Okay. Yeah. So I'm Dr. Shrestha. I'm a rheumatologist. I'm duly accredited in medicine and rheumatology. I work at East Kent. Been a consultant for nearly 8 years now. I'm clinical lead for rheumatology. Been an audit lead as well, and I'm also deputy lead for in rheumatology for complex a regional rheumatological network. And joint secretary. So.
Thank you, Dr. Shrestha. Mr. Harinath, would you like to say some few words?
Well, first of all, this is it's a very, very a special feeling, because I'm involving myself in this sort of a meeting for the first time. And I got a special connection with Nepal, because I got few excellent Nepali consultants who have been part of our department. I got special relations with Nepal anyway, so that's a different matter. So I've been a colorectal surgeon in my hospital nearly 20 years. I did my medicine from Venkateswara University, Tirupati. Then I did my post-graduation from Chandigarh, PGI MER. Then I came to UK. I had to, like any other international graduate, you will have to work your way up. It's a challenge, but there is a way to do it. And I'm sure you will uncover these things as you are really serious. Means you will get around, like Mr. Shrestha has done, Mrs. Shrestha has done, like I have done. So it is possible to do it. So you need to be passionate about exploring these things. In terms of my experience, I'm a colorectal surgeon, general surgeon. I do emergency surgery, laparoscopic surgery, and I do general pediatric surgery. And we're hopefully going to start some robotic surgery as well before I retire, hopefully. Yeah, I'm very happy to take any questions related to news. But my experience with news, I don't know if this is the main topic of discussion today. Mrs. Shrestha, Dr. Shrestha, shall we say, has already highlighted, and you have to be going by not just one parameter. Don't just trust only news. The individual parameters within news can be different, and it may deceive you. So don't just trust the numbers only. Just look at the patient, review the whole history examination. That you can't replace the clinical experience. So just go and see the patient.
Thank you, Mr. Harinath. Could Mr. Ariel also introduce himself? He's previously the chairman of the NDA and a profound surgeon as well. Dr. Ariel, would you like to say some words?
Thank you. I think Dr. Shrestha has introduced, but in brief, I'm Nepalese originally. I went to Ganaki boarding school in Pokhara. After graduating, I did a couple of years of ISCU, used to call it in Amrit campus, hospital. Then I went to Calcutta to study medicine, the oldest medical school in Southeast Asia. Then after studying there, I came back to Nepal, and that time we could do FRCS in Nepal itself. So I did that and came to UK in 2000. So I have been here for a long time. And I was trained around Northwest, some training around Birmingham. Then I did laparoscopic colorectal, advanced colorectal fellowship in Nine Wells Hospital in Dundee. Then I have been a consultant for about 14 years now in Greater Yarmouth. In addition, I am core surgery TPD. I'm member of the Specialty Advisory Committee for General Surgery. I'm also Regional Surgical Advisor for Royal College of Surgeons of Edinburgh. So those are my portfolio. Thank you.
Thank you, Mr. Ariel. So we have a panel who's got a lot of experience, clearly. So I would like to start by asking some questions to all of you, and then you can answer in turn. So could you, so as IMGs, could you share us some anecdotes or some things that you've experienced as an IMG when you came to NHS, like in terms of culture differences? What are the main things that you found different practicing back home and coming to the NHS? What were some of the things that stood out for you? And what would you give the IMGs who are, looking to come to the UK? What advice would you give them to adapt to these differences?
Mr. Harinath, do you want to go first?
Yeah, well, thank you. I never practiced in India. I did only postgraduate training, but obviously I've been exposed to the patients during my undergraduation and post-graduation. So the expectation from doctors in India is different compared to here. So patients do expect respect, dignity, to be addressed with a name, and they expect they've got their rights, and they expect you to come and talk to them. I'm pretty sure that's the case in India as well. But if you are a little bit less in terms of communication, you may still get away in Asian countries. I'm pretty sure patients will really expect you, and they love you if you are really communicating with them. And that I don't think is hugely different nowadays, because the standards, I would say, have gone up. Patients' expectation is improved, and if you are not really communicating well, they think that you're hiding something, and then sometimes there is violence against doctors. And I've seen that I've heard that from my friends in India, that there is hostility between patients and doctors are the families, because there's poor communication. So I think the key is communicate well wherever you are. That is the most important. But then here, I would say if you are in the UK, the communication is so important. You will have to take that really seriously. And that's the first thing about communication. There are several differences, obviously, because you will have to be more disciplined, you have to be honest, you have to be completing your appraisals, you have to collect all your documents on your practice, your clinical work, your results. It is really, really important. I'm pretty sure in Nepal and in India, nowadays everybody is talking about attending meetings, CPD points, appraisals, and everything is also catching up. So probably it's not hugely different nowadays, but I think compared to what I saw many, many years ago in India, those days things were very primitive. So now the expectation has gone up from public, and the performance of clinicians is and the documentation, appraisals, everything is becoming gradually international. So it's accepted now that you're supposed to keep your documents, your results, and if someone questions you, you need to be able to produce those things. And yes, studying, reading is part of our life, so we'll have to carry on. It doesn't matter where you are. So keep up to date. And the principles of maintaining high standards is required everywhere. It doesn't mean that if you are in Nepal or India, you have to give substandard service. Patients are same everywhere. They do expect, but they probably respect more in Nepal and India. They have got more respect for doctors. Here, although the respect is there, it is not expressed. So all they expect from you is to do your job, communicate well. But in Asian countries, if you do a job well, don't communicate, still you may get away. All they're looking is probably results. What else I would like to say? It's important to be up to date with the knowledge, appraisals, and GMC revalidation. All that is important in the UK. In India, I don't think there is a revalidation system yet. I'm sure they will catch up. And that's going to be the case in Nepal too. So it's a matter of time. So high standards are required everywhere, because at the end of the day, they are patients, and one day we'll be in that position, and we will need somebody who is treating us to look after as well.
Thank you, Mr. Harinath. Dr. Shrestha, would you like to say some few words regarding this matter?
Yeah, so I think the main mindset change when we work in the NHS or in UK, I think from my personal experience, like back in Nepal, it was obviously you do the best for your patients wherever you are, and you are, patient focused, but it's not the same level of patient-centered care that we have here. And we or I did at that time. I think times are changing, like in India and Nepal as well. But it is, from me as a doctor who is the important part in the hospital, and I'm important to, changing the focus into the patient being the center of care. And as Mr. Harinath said, communication, and they have certain expectation, and it's quite important to meet that. But I will go further from that. It is not only having that communication, clear line of communication with the patients. It's very important to have that with everyone in the hospital, your colleagues, because your nursing teams are very, very important here. And, if you work in a ward, and you're not, working as a team with the nurses or respecting them, communicating with them very well, it's very hard to work in a ward environment, or even in, say, rheumatology, where we have lots of nurses. So it's very important to have that kind of a teamwork spirit. And you are just part, as doctors, we are important. I'm not saying we are, and we take the main burden of decision making and treating the patient, but you are still one cog in the wheel. So it is to change that mindset. We are a team. We're not the most important, and patient is at the center of all of this. So I think that is the main kind of culture change, or a mindset change that we need to make. And I think I wouldn't say it's easy. It is very hard when you come and make that transition, and the rules are ever changing, and it's not easy. But if you persevere, if you work hard, you will get there. It's when we came, there was something called MTAS, and it was not easy to get job. It kind of almost automatically excluded a lot of IMGs being given a training post. So but it's never to give up, and keep working on self-improvement. And a lot of the time in the NHS, even when you get a job, you will say, if you're in IMT training, you will get your training days, you have to do your exams, but it is adult learning. Okay, it's not like in medical school, or when you do postgraduate thing in Nepal, you'll have lots of exam. You're supposed to do this, that, fill up assignments. Here, everything should be led by you, and you will be working. You will be doing your on calls, and you still have to do your MRCP. You still have to do this, that, your audit. So there's a lot of things you have to do while working. So nobody's going to spoon feed you. It's an adult learning theory. You have to be quite proactive in doing all of that. So I think that's another difference, I would say. And I think one thing that we must mention is, I think Mr. Harinath mentioned as well, it is the honesty. So, it's never lie, never hide things. If you made a mistake, own up, because the consequences of lying and trying to, hide things is even greater, because you'll have probity issues with the GMC. So if you've made a mistake, everyone makes a mistake. You need to own up and correct it. And oh, someone's and I think that is probity is very, very important. So I would say that in the first instance. Yeah.
Thank you, Dr. Shrestha. Mr. Ariel, would you like to say a few words about this matter?
It will be quite useful to know, isn't the audience, because the question is perhaps relevant if you are coming to UK, but if you are still in Nepal, then
I think most of them are in Nepal, and there are quite a few clinical attaches, and who's doing clinical attachment here in UK. So I think there are there are a few of them who have already done MRCS or similar degree.
And are these programs we have got different themes on different days, yeah?
Yeah,
sometimes we have got some sessions we have got for those who may be in Nepal and trying to get to UK, how they can get to, and for those after coming to UK, what problems may be there. So your question is mainly relevant for those people who are in UK, or perhaps for those who are in Nepal who will come to UK in the future. So what sort of things they need to be careful about, or how they can be adapted in the National Health Service at the initial days. Is that the question?
Exactly. People who are either here or in Nepal who are highly interested in joining the NHS. We just wanted to, shed a light from your perspective, like what you found different from the healthcare service back in Nepal and the NHS. the cultural differences as well as like how the system operates is what the question. Yeah.
Okay. So my time was quite long time ago, 25 years ago. So I'll give a little bit perspective at that. And as the previous speaker said, things have changed quite a bit since then, and many of the things are so modern and good both in Nepal and India, so the things may be slightly different. First of all, the difficulty or challenge I found was to get the job in the UK. I've done my FRCS, many of you have done MRCS. If you do that, you don't need a PLAB registration. And once you have done the exam, you can apply for the job directly. But nobody will give you the first job because they will say you didn't have the first job in UK. So clinical attachment, many of you are doing, so that is a good way to get to. I was doing clinical attachment. I applied more than 300 applications, and after that I got interview. After about 3 or 4 interviews, I got the first job or first training, whatever you call it. But once you get that first post, it's quite a bit of a struggle because everything you have been speaking or interacting with patients in Nepal and things around here are quite different. And some of them came about. So expressing yourself, and then honesty came about, and talking to the consultants and telling about the patient. Sometimes if you don't know the results, tell them, I'm sorry, I don't know, don't make it up, and tell them something else which you don't know to prove that you may have seen the result or whatever. So that is that. Then communication is very important here. I think that has already been highlighted. Still, they say the communication is not good, but for those who are coming from abroad, our communication needs to be much better. Again, that can be done. English language is generally good because you will have done the exam and come here. But just being honest and frank and considerate and respectful, that is all required. Particularly with the patients, I remember going for interview myself, and they said the NHS, I had been working for a few years. What is the difference between the NHS and the country where you come from? And the main difference, I said, is the patients are treated with compassion and dignity. So that's the great difference. I hope that sort of compassion and dignity is there also in Nepal and India now, which was a bit less when we were there. I think those are the main bits.
I think, Dr. Arial, I think that's a very good point. And Dr. Parul and Mr. Harinath. Reflective learning is what we do most of the time. Unconsciously, we're also doing reflective learning. All our training here in UK is based on reflective learning. All the assessment, the work-based assessment are based on reflection. I think that's one way of very good learning that I probably have I've taken from being in UK. Dr. Arial, do you want to say what courses you're going to do in your recent visit and next visit while you're in the forum?
Yeah, I will. Yeah. And one other thing is slight difference between Nepal and here. Seeing the trainees going to Nepal and also being involved on this sort of sessions and having seen their CV, clinically they are very good in Nepal. Whoever is working, the clinical standards are good, knowledge is good. When you go to the exams, then the candidates who are here exactly say how the things are done here. But unfortunately, MRCS exam, for example, but some of the things may not be done exactly the same way as they are done here, the way they are done in Nepal, so it may not be the same. The other bit we slightly lack in Nepal is doing these audits and completing the loop publications and also presenting these different meetings and conferences. Those are some of the things. Teaching is the other one. So not only doing those, but making sure you collect those evidences for all of those. Yeah. So next bit, sorry, Assis, I went off a bit there, so out there. So the next visit we are going to do is laparoscopic course, which I've been doing for last 10 years. So it will be the 11th year. We used to do it on the simulators, but from last year we have started in doing in the porcine tissue, the white tissue, so that it is more realistic. So they will be removing the gallbladder, doing gastrojejunostomy, suturing, that sort of thing. Also theater exposure. So that is 3 days at the Likel Hospital. And then we also run non-technical skills for surgeons. Technical skills are important for surgeons, but to complement that skill and to become even better surgeon, you need to have some non-technical skills as well. And some of that difference we talked about earlier may be related to that. Clinically we are good, but other things like social skills, the communication, teamwork, leadership, and also understanding of those cognitive skills like situation awareness and decision making. So that could be better perhaps. So we have been doing that course for the surgeons in Nepal for last 6 years or so. That will be our 7th course. We have also been going to Pokhara for last 3-4 years, just expanding that laparoscopic course. We'll continue to do that. Last year even we went to Jumla, but this year we want to be able to go there. So that is the plan so far. Yeah.
Mr. Harinath, as he explained, so thank you, Dr. Aryal. Mr. Harinath is he's falling in love with Nepal. He went for a Mahdi base camp last year. Now he's going to go for an Annapurna base camp. So while he's going there, we're taking the opportunity. Hopefully, we can organize a talk program in Nepal, so that he can give a talk in one of the hospital. Simos.
Yeah, sorry, Mr. Harinath will be back. He's got something. He'll join us again. But I'll ask another question in line with what Sujata Shrestha on the comment has asked. So she's asked, what are the common pitfalls new doctors face and how to avoid them? So to expand on this question, I think I'll ask, what are the common pitfalls, like new doctors, especially IMGs and clinical attaches who come into NHS? What are the common errors and mistakes they made? How to avoid them? And I also wanted to ask you guys to give some insight on learning from this and like professional development opportunities in NHS compared to back home. What opportunities exist within UK in the NHS for education, career progression, and what are the support systems and resources within the NHS that IMGs can utilize to, progress their career and grow as a professional doctor? Could you shed some light on that?
I think I can answer that. So in terms of the pitfalls, I think, as we said, we just can't emphasize on communication skills more. And it is, I think if you at least, when in a clinical scenario, I see that, it's difficult for IMGs, and I face that as well, to present a case or, do a handover effectively. We can hand over, but it has to be quite effective. And I think Mr. Anang Pangeni put a link. So it is, you follow an IS-bar format or a S-bar format. So it is kind of tells you, you introduce yourself, situation, background, assessment, and recommendation. So if you start practicing that from now, even if you're in Nepal, how you would, present a case or, hand over a case, I think that would help when you come here and you have to do the same, because you have to make it quite succinct. So I think with regards to the communication, it's very simple. You can start doing that from now, how you would, hand over a case or present a case, to make it very succinct. I think the other thing is, in terms of the clinical skills, when you come from Nepal, I think you do have a lot of clinical skills as well. But so sometimes we so if I just give an example, when I came, and it may not be true now. So in Nepal, a lot of our nurses do the venflons, they do the catheters, doctors don't have to do those kind of smaller kind of skill-based jobs. And what I found is when I came, I could do central line, I can do appendectomy, but I can't put a venflon properly or a catheter because nurses would do that. So it is the basic simple jobs that I think is quite important if you don't know or you're not used to doing, to learn that as well. So I think that's one. So to answer your second part of the question, which is what opportunities are there for IMGs, I think there are loads and loads. Okay, so it's just being open to those and being very proactive and asking people around you, or even forum like this, to see what opportunities. So obviously there's opportunity for career progression, which if you did exams and you did your training, you'd normally go up the ladder anyway. But there's also a lot of opportunities for research, for audit, teaching. There's in most hospitals there are medical students. You can teach F1s, F2s, so there's a lot of teaching opportunities. You just have to grab those. And a lot of places will also have other kind of opportunities, like you can be mentored, so you can ask for mentors in the hospital. You can, some places may have coaching as well, so you can have mentorship from that. I know the NDA, we will also open up the mentorship program in near future, very soon. So there's opportunities for that. But if I give my own example, you can do a lot. So you can be leaders in the NHS, and it doesn't matter because, and it's quite fair. It doesn't matter if you're a woman. It doesn't matter if you're working part-time. If you have the skills and the dedication, you can be, in leadership positions as well. So you've got lots of opportunity to grow in the NHS. So if I just want to give an example, because at this age, I've got an opportunity to do a second master's, and that's through the NHS. It's an apprenticeship skill. So there is so much that is on offer, if you're willing to grasp those. So it's loads and loads of opportunities, but you have to make sure you're working hard. We have to work. I think Ashish always says, as IMGs, you have to work double what others do. You always have to work much harder, but yeah, there's loads of opportunities.
It's not even double, it's 10 times.
Yeah. And Mr. Ariel?
So just to know how to avail those opportunities may be a bit tricky, because when there are so many opportunities,
Exactly.
how to choose maybe a bit. So, but that will come with time. And around the procedural skills, Dr. Parul mentioned. So if you do things, then don't forget to document it. I've heard that sometimes people do some things and they document, and that will create problem. Make sure anything you do, important things you communicate, that needs to be documented in the notes. When you document it legibly. Make sure you write your name, your level, what post you are on, and your click number. So that is very important. Yeah. And also once you come, if you are new to the NHS, many places have got systems of induction for overseas trainees, and they are conducted by colleges sometimes by the deaneries, couple of days, and they go through all the difficulties faced by the international medical graduates. So all of those, including account opening in the bank, all those things, national insurance card, all those different things, driving license, that sort of things. Yeah.
I think there's also something on BMA website for IMGs as well, as far as I'm aware. So they're quite good, useful links as well on the BMA.
Yeah. And NDA, we are doing these things, so we'll
Yeah.
try to make a section, I think, for the overseas doctors type of thing, and we'll try to keep those links on that folder. I think we need to do that. Yeah, I think there is some already, but we just need to develop.
I think we have few from the webinars from the past, and last webinars was on applications for various specialty, PLAB and so on. I think that will give a lot of information to the attendees out here. If you want to have a look at the webinars, we'll try to put the videos and the slides that we discussed last time. Currently, I'll have to be really honest with all of you. The job situation in UK is especially if you're applying for any resident doctor post at the level of foundation year or core trainees, even at the register level, is quite competitive. We get for one job we can get 1,000 application, even while filling the application form. I think those forms are taken out fairly quickly. The advertisement are taken out fairly quickly out. I've shared a slide, one of the slides in the chat box. It shows that the IMG coming from Nepal, who has graduated from Nepal. You can see there's quite a rise of peak between 2023 and 2024, but the peak has suddenly come down. The reason is that people found out there's quite a competitive to get a job in UK. So I think it might have been people might have been discouraged to come to UK. So it's difficult, but as we discussed last time, if we keep on persevering, the course like this, which has got a CPT accreditation from Royal College of Surgeons of Edinburgh, will add a lot of value to your portfolio also. Mr. Harinath is
I
here.
think Mr. Harinath is back with us now.
Yeah.
Before we derail from the question, is Mr. Harinath, would you like to say anything about mistakes and common pitfalls of IMGs?
Yeah, sorry, I was briefly away because I had some personal problem. Right, so common mistakes. I think I will start off with strengths first because our training, I would say both in Nepal, India, is quite robust. It's very good training. The exposure to the kind of material, patients, the extent of pathology we see is amazing. We don't see that much of variation and the severity of cases you don't see here. But we've got a different kind of challenge. So we're exposed to see very, very complicated cases, complex cases, complex scenarios. And therefore, our clinical acumen is very good. And not that I'm a surgeon and I want to praise surgeons. The surgical skills that you acquire in Nepal and in India is amazing. So there's quite a lot of surgical skill you come out if you are actually coming out as a postgraduate trainee from Nepal and India. So you already got so much of wealth of experience already. So it's really the great strength. My first comment about the mistakes I will say is actually we tend to underestimate ourselves. So don't ever underestimate yourselves because you're well-trained, well-rounded training. But here the training is different. That suits the local requirements, of course. But I would say be strong and you already fully trained. Don't underestimate yourself. That's the first thing I'd say. Second thing is the communication. So we tend to not to say if there is any mistake from our part, we tend to not to say. But then obviously that's not a great thing. So if you make any mistake, you have to admit, and that way things will it'll take a different shape. Okay, different consequences. Okay. You tend to work hard, like Nepal, India, people work long hours, longer than expected. And when you come to UK, you got time limits. So you come on time, you're expected to work up to a particular point, say 5 o'clock or 6 o'clock, whatever. You don't need to work beyond. So, but then you tend to work longer. So that's one of the mistakes I've seen. That is maybe your own commitment, or maybe you want to work, but then that won't be recognized in a way that they don't expect you, first of all. So I think working longer is a mistake. It doesn't really help you. And the other mistake is we all make mistakes. We can forget things. We can forget patients. We can forget to check the results and so on. So it's really important that we complete our jobs. So completing our designated jobs is important. You don't need to really help others, but yes, when we are back home, we help each other. We like to be part of a team and so on. So here, you don't need to, but yes, increasingly that's I would say it's a strength in a way. But again, you don't need to stay extra 2 hours to help your own friends and so on. So if you're able to help, that's different. But yes, there's no expectation. Common mistakes. I don't know what else I can add in terms of mistakes, but you need to be on time. So you need to be on time. And when you're ill, say that you're ill. You don't need to be really bending backwards to come, because you are protected. If you're unwell, you're unwell. So back home, you may even work when you got fever, when you're ill, you may still come and work for whatever reason. But here you're protected, so you don't need to bend backwards here. So just be honest, and that's all I would say. Going to the second part, opportunities. Parul has already mentioned. There's so many opportunities. It all depends on where you want to take your career. I would say one of our own, my own junior colleague has become a president of Association of Colorectal Proctology. So there is no limit. So if you are capable, and if you're keen, and you are aspiring, you can achieve anything. Mr. Shresh has already highlighted, it's going to be hard, but that's fine, because you're interested, you will do it. The opportunities are limited, certainly limited in the current financial climate, when they're trying to cut down the appointments and so on. So the opportunities are limited, but once you're in, the opportunities are boundless. So you can achieve what you want. You can be a consultant, you can be a professor, you can be anything, really. Honestly, you need to show your energy, passion, enthusiasm, and keep at it all the time, and you will achieve things. Don't be put off, but yes, there are too many applications, and that's how the world is. So what can you do?
Thank you, Mr. Harinath. That was very insightful. Dr. Gakul, I think you had your hand raised. Did you have something to input on this matter?
Yeah, I wanted to say something about the job market at the moment, and also the differences that we had when we were in Nepal or overseas somewhere, and here. So yeah, the job market is tight. We all know why, but when I reviewed a few of the CVs that IMG sent to me, I think we lag behind our, things that we have done. We are a bit behind in documenting things that we already do. We are doing things like that. So at the moment, all the applications for the job would be sorted out through automated computer system or through the medical staffing department. So you are unlikely to be invited for the interview if you don't put things like there's a mandatory things and good to have things in the advertisement. So if you don't put everything, yes, I have done this, yes, I have done this, you are unlikely to be invited, I think. And you cannot just put there, you have to show evidence later on. And so we reviewed few CVs in the last couple of weeks, and I know these guys have done all of these things, but they haven't put. So all we do is like, we are very good at knowledge and skills. For example, surgical applications, I can do appendix, I can do this operation, I can do that operation, I can do this, but nothing beyond that. So there's a lot other elements in our field than just the clinical knowledge and skills. Leadership, patient safety, MDT, all, I mean, there's so many domains. So the job description normally explain all these things, what you need, and you have to tailor your CVs as per this one. Otherwise, unlikely to be invited. That's one thing. And the second thing, the way we are trained overseas and here, I mean, most of the things has come up, but the one I have seen is that we can have so much variation between different hospitals or different institutions overseas. So here, of course, variable as well. Here is not no one. I mean, it's not the same every hospital or every deanery here, but there's minimum standard that's been maintained. That's all.
Sorry, can I just mention, as Gokul's mentioned, he's reviewed some of the CVs, and I think in one of these sessions we need to perhaps look at, how to write your CV or tailor your CV, and what are the things that you should do. It's something to think about, isn't it?
Yes,